Thank you so much for the kind introduction, sir. And I would like to thank the organizers for giving me this opportunity. So let's go back to basics and we will discuss. I hope my screen is visible.
Yes, ma'am. Yes.
Okay, shall we start?
Sure, sure, please.
Uh, so topic for today will be molecular profiling of non-small cell carcinoma lung. We all know how much important histology is in when it comes to non-small cell carcinoma. Why this histology is important? It is because of the underlying molecular heterogeneity that we see in these adenocarcinomas, which has a wide range of molecular drivers, way different from those in the squamous cell carcinomas that have mainly PIK3CA, FGFR1. But when it comes to adenocarcinomas, we have EGFRs, the most common ones. Back in 2018, the CAP had provided guidelines for must-test genes, which included only EGFR, ALK, and ROS1. Then came an expanded panel, which included BRAF, MET, RET, ERBB2, and KRAS. Then came comprehensive panels, which included both must-test genes and the expanded panel. Now, how has this mutation testing in lung cancer evolved? Let's have a look at the NCCN guidelines. Earlier, only 4 molecular markers were mandatory, which were the actionable drivers, the EGFR, ALK, ROS1, BRAF, along with PDL1. Then in 2020, the list expanded. It added more to it with MET, RET, and ROS1, BRAF also. And this list, because of the targeted therapy available for all these molecular targets, the testing has also increased. Now let us have a look at each one of them. Starting with the most common, that is the EGFR, favorite of all, known as the HER1 or ERBB1 also. It is found on the surface epithelium and often overexpressed in a variety of human malignancies apart from lung. It is seen in non-smoker women of Asian descent with adenocarcinoma histology. Patients with pure squamous cells are unlikely to have the sensitizing mutation, while with adenocarcinoma or adenosquamous may have this. TKIs definitely show clinical benefit, but the likelihood of this response is relative to the location of the mutation. The mutation of EGFR usually lies between exon 18 to 21. In exon 18, we have the mutation 719X, 709X, and also the deletion. But the most notorious ones are the commonest ones found are exon 19 deletion or maybe the exon 21 mutation. Apart from them, we come across rare mutations. Now, what are these rare mutations? Exon 20 insertions, L861X, S768I, and many more. So these newer mutations are being disclosed because some of them are responsible for the resistance, like the T790M or the notorious one C797S. Now these mutations, they are responsible for the TKI sensitivity, but also for the resistance. The one in the greens are, yes, a green signal to go ahead, but the resistance mutation, the T761Y in exon 19, and likewise T770 in exon 20, T790M are responsible for the resistance. Now coming to the next common, anaplastic lymphoma kinase, that is the ALK, in ALK gene located on short arm of chromosome 2, encoding receptor tyrosine kinase belonging to insulin receptor superfamily. ALK not only undergoes amplification but also fusions and mutations, not only in non-small but also in anaplastic large cell lymphomas, neuroblastomas. It has various fusion partners, but the most common is the EML4 ALK. Frequency in lung cancer is around 4 to 5%, observed in young women with a history of light or never smoking. Now, when this fusion happens, this leads to proliferation and cell survival through various pathways. ROS1, located on chromosome 6 longa, it is a receptor tyrosine kinase involved in various human cancers like gastric, ovarian, cholangio, colorectal, angio, apart from lung. It also has various fusion partners which constitutively activate it and drive the cell proliferation. seen in around 1% in non-small cell, and also the preclinical evaluation translocation positive shows strong sensitivity to crizotinib. That's how the ALK and the ROS1 fusion, when they are targeted, they, they are responsible for activation through three separate signaling pathways, like the JAK-STAT pathway, the RAS-RAF pathway, and the PIK3-mTOR pathway. Coming to BRAF, a member of RAF family, located in chromosome 7 long arm. It has a role in regulating the kinase signaling pathway, which affects cell division, differentiation, and secretion. Yes, the most common V600E, apart from lung, seen in melanomas, non-Hodgkin lymphomas, colorectal, thyroid, and hairy cell. This has been determined to be an activating mutation, the V600E. And the cells that harbor it, along with other mutations, they are sensitive to the BRAF inhibitor, dabrafenib, and others. Coming to the KRAS, located in chromosome 12, short arm. It is the Christine rat sarcoma, member of GTP family, responsible for pro-survival signaling. It's most commonly mutated amongst the RAS family in non-small cell. It is frequently observed in smokers, and the incidence in non-smokers around 15%. These mutations usually cluster in the codon 12, 13, and 61, and they dictate a poor prognosis towards when present when compared to the patients without mutation. The mutations are substitution, insertion, or deletions, and they show reduced responsiveness to EGFR TKI. Currently, drug targeting involves combination therapy to circumvent the resistance. Now, that's how KRAS functions in a normal cell and a tumor cell. So, when we have a wild type KRAS, when a ligand is bound at the membrane, then the downstream signaling pathway is activated. While in a tumor cell, in case of mutant KRAS, which arrests the GTP, and in the absence of the ligand, there is downstream signaling, continuous downstream signaling to the cell nucleus. Coming to the next one, that is MET, located chromosome 7, long arm. MET is nothing but mesenchymal to epithelial transition genes, discovered in late 1980s. It also encodes for a receptor tyrosine kinase, which regulates a multitude of cell processes like the cell scattering, invasion, apoptosis, angiogenesis. It is most commonly seen in smokers and older patients and also linked to poor clinical outcome. MET alterations in non-small cell include mutations, exon 14 skipping, which is a targetable gene alteration. It also, this MET skipping, when present, it leads to the loss of CBL binding site. So there is impaired receptor degradation and leading to increased MET signaling. This skipping occurs in around 5% of the non-small cell, seen in both squamous and adenocarcinoma histology. RET, the receptor tyrosine kinase that affects cell proliferation and differentiation. This RET undergoes rearrangement, seen in around 1 to 2% of the non-small cell cancers, and are frequent in patients of adenocarcinoma histology. Now, this rearrangement can be with different partners, most commonly with the kinesin family B, also with coil-coil domain containing C or NCOI4. The presence of this rearrangement is associated with increased responsiveness to oral RET TKIs, regardless of the fusion partner. The commoner ones, the NTRK123, most commonly seen in the soft tissues, located on chromosome 1, 9, and 15 respectively. They are transmembrane receptor tyrosine kinases having a high affinity for neurotropins and are implicated in neuronal development and differentiation. They are in-frame fusions. They often occur in rare malignancies but are seen rarely in commonly occurring malignancies. Upon binding by the ligand, like the NGF or others, on the extracellular domain, there occurs phosphorylation of the tyrosine residues and downstream signaling. While in case of the altered TRKs, there can be phosphorylation of the residues independent of the ligand binding. The HER2 or the ERBB2 widely utilized biomarker in breast cancer, which undergoes amplification in 15 to 25% of the cases. However, in non-small cell, it is the mutations that are seen in the exon 20 or the in-frame insertion that we see most commonly. The mutation frequency is definitely lower than the amplification, and the clinical response is also towards the anti-HER2 directed therapy. The MAP2 kinase one, which is usually considered as a pivotal in resistance to the targeted therapy approaches. MAP2 kinase 1 located on chromosome 15 longa, and it is considered to be mutually exclusive from the known driver mutations. They have a strong association with smoking. Now, after knowing all these molecular drivers, there are certain recommendations and challenges that as a molecular lab we face. The recommendations are the pre-procedural discussions at multidisciplinary lung tumor board. The pathologist should determine the adequacy, prioritizing of the tissue for testing of the actionable oncogenes, and the procedures for quality control and proficiency. Now, what are the challenges? The challenges are the biopsy may not be sufficient, or the diagnosis based on morphological criteria may not be possible with need of IHC to subtype it, and the differing tissue fixatives, processing protocols, storage conditions affecting the sample usually. Under normal circumstances, this is what happens when a tumor biopsy with finite tissue appears to lab. It undergoes histology with more than 2 cancer slides. Then there is subclassification, one more slide is gone. So the diagnosis adenocarcinoma, for example, which then undergoes EGFR 5 micron tissue gone. And then we need few more markers, then BRAF, PIK3, FGFR, for example. Then we might need IHC by ALK by IHC, 2 more slides required. If it is equivocal, we require FISH, 2 more slides required there. And then when the patient ends up in the relapse, the pizza that we started with is not left with any. So we feel a need to shift to universal testing platforms. Like the current practices are not sustainable for laboratories, confusing both physicians and regulators. So moving forwards, we recommend one patient, one test. How could that be? So for that, we need to choose the method. Now, the method has to be focused on the sensitivity, the time, the money, everything. When you combine all the features, it is the next generation sequencing, which provides you with sensitivity as good as, which can be done on tumor tissue and multiple targets at one time. The test that we see, why NGS? Because it tests many mutations. We can undergo a panel at a time, which is not the case for ddPCR, which is not the case for real-time PCR. Yes, for cheaper, it falls cheaper per mutation. It has a longer TAT, definitely, which is a major drawback, but it can be done for tissue. With in one go, you can cover the entire panel. So we offer customized panel using FISH. We have ALK, ROS1, MET amplification, which is the cancer targeted gene panel. With FISH and NGS Club, we have MET mutation, KRAS, BRAF, ERBB2, and EGFR. Or else we have a 12-gene lung cancer panel, which is with PDL1, SP142 or 263, and covering 12 genes and hotspot genes as well as fusions. Or we have Oncomine Focus Assay, which is 52 genes covering all the hotspots, CNVs, indels, and gene fusions. So this is a recent study of 950 samples that we have done in the past 1 year. Yes, most common being the EGFR, apart from no pathogenic, followed by KRAS and PIK3CA. So my take-home message would be optimal tissue sampling and management is the key to identifying prognostically important genetic subtypes in lung cancer. Individual gene testing is still going on, but we need to graduate to multi-gene testing in view of limited tissue sample. Liquid biopsy, highly sensitive, need no biopsy, but it is single mutation testing. NGS can identify all driving mutations, opening doors to newer therapeutic options and clinical trial scenarios. It is tissue proficient, better half for precision medicine. RNA-based sequencing has overcome most of the shortfalls of existing NGS-based DNA sequencing. And thank you.
Thank you, Dr. Richa, for giving a wonderful talk on various molecular markers in NSCLC. May I ask you one or two questions?
Sure, sir. Sure,
Yeah,
sir.
yeah, yeah. So, just two questions. Like one is you talked about liquid biopsy. So
Yes, sir.
today only I have one patient. So taking that patient as an example, so he came to me as a, severe breathlessness patient with on oxygen, and he was
Mhm.
carrying a report of a biopsy lung CT guided adenocarcinoma, but sample was not sufficient to carry on further testing. So he was admitted, and someone has advised to go for bronchoscopy, EBUS, biopsy, blah blah blah. So he underwent that, but before that I sent the sample for ddPCR, and I got the report exon 19 deletion. So here are two questions, and EBUS biopsy again sample was not sufficient. In fact, there was no malignancy in that, so that was futile exercises. So there are two questions which I want to ask you. If that patient or any patient, if we don't have the histopathology report of adenocarcinoma, how much comfortable we are in starting the treatment based on ddPCR? That is question
Sir,
number one.
yes, sir. Sir, I don't think if the histopath report is unavailable, so we should, wait for the treatment. Yes, EGFR sensitivity is there for ddPCR, so we can start the treatment, in my opinion.
Right, right. So, thankfully, I got the report in 3 days' time from your lab only. Today only I got the report. I was about to start the chemotherapy, but immediately I got the report. It is positive. So another thing, like foundation assay, we are sending the sample sometime tissue block, biopsy block sample, and they say that sample is not adequate. So they run the sample, they run the test on blood sample. So, how much we can adopt this liquid biopsy sort of thing as a comprehensive panel by NGS, like some of the Indian company are also doing, labs are doing, but I think Lal Lab is not doing on liquid biopsy as a comprehensive NGS. But how much we are comfortable in accepting that report?
Sir, definitely liquid biopsy is the future because the report, the TAP that we have is lesser compared to NGS. But in case we have a block, I think NGS for solid tumor on the block should be done before going for liquid biopsy. Liquid biopsy should be the last option. And yes, it is good, it is sensitive, if it gives you comprehensive report.
So that's what I was asking. If biopsy is not feasible, patient is sick. So if that report comes negative in terms of all the molecular markers, so we are okay in accepting that report, or still we should try for the biopsy.
No, sir, I don't think because
So if
you have gone for yes, it can be acceptable, sir.
it can be acceptable.
Yes, sir.
Okay. So there are some technical change things that some labs are doing and some labs are not doing.
Sir, it actually the process protocol and the availability of liquid biopsy is way different from the processing of the rest of the molecular tests that we are doing. So it is the time lag that is there. In some near future, definitely all the labs will be doing that.
Okay. 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 Right. Right. Thank you. Thank you, Dr. Richa. Thank
You're
you.
welcome, sir.
Right. So after this discussion, so we'll move on to the next talk. So next session is by AstraZeneca, sponsored by AstraZeneca, and the topic is turning the tides for stage 3 in NSCLC towards the curative intent. Because we know that stage 3 non-small cell lung cancers, most of the time we give CTRT and there are some residual disease, even after giving some sort of adjuvant chemotherapy 2 or 3 cycle, and then we have to wait for recurrences or again progression to start the second line sort of treatment. So there that area was vacant till few years back, I think 2 3 years back. So there are trials and which and now we are using in routine practice. So for this talk I would